So welcome, as I said, to our EHDS Unpacked webinar. This is part two of our two-part EHDS Unpacked webinar series, kindly sponsored by Wellcome Trust. So part two is covering global lessons for building a trusted health data space. Perfect. So just a little bit of background on UPD, who we are, what we do. So we are driven by the mission of making uses of patient data more visible, trustworthy, and understandable, whether exploring data use for research and planning purposes, informing policy initiatives and health data reforms, or researching attitudes around health data collection and use by minoritized communities. Next slide, please, Nadia. Thank you. So these three values underpin all of our work and have been the driving factor to shaping today's webinar, which is designed to bring light to how other countries are approaching the European health data space and their respective data networks through public engagement, trust, and innovation. Next slide, please. A little bit of background on the work that UPD has been doing around the European health data space so far. So this is building on UPD's 2023 report on UK public attitudes to the European health data space, informed by citizen consultations in the UK, France, and Belgium, and an expert roundtable in autumn of last year, which convened UK experts to understand the level of awareness around the European health data space and clarify interest. So we are currently running an exciting programme of engagement events, including 2 open webinars, the second of which you're attending today, a hackathon with other non-EU third countries in May to build shared insight and alliances, and we're convening UK experts in London towards the end of May as well to shape input into the next consultation, alongside supporting UK experts to attend different TEDAS workshops throughout this period. Off the back of this, we'll be producing and sharing lots of practical outputs, including explainers, summary reports, and case studies, alongside supporting parliamentary activity to ensure that ministers, MPs, and civil servants are all up to date and engaged with this agenda. So lots of really exciting work that we've been doing, are doing, and we have coming up too. Next slide, please, Nadia. Okay, so over to you, just to get an idea of how much you feel you know about the European health data space right now, to kick us off. So we also did this at the start of our first webinar and at the end, just to get an idea of how much understanding grew. And we're doing it at this one as well, just to get an idea of how much that is changing. So if you could scan that QR code and let us know how much you know about the European health data space right now. So as we're starting today's session. Okay, nice. We've got a lot coming in. Okay, let's move over to the second. Oh, no, it's still going. A great deal. Ooh. Okay, let's move over to the next one then, please, Nadia. So the next question is, what importance or relevance do you think the European health data space holds for the UK? So again, if you scan the QR code or head to slido.com and pop in that number. Okay, that's great to see. Oh, let's move it on to the next slide then, please, Nadia. Thank you. So to support your understanding of the European health data space, hopefully move you from a little or moderate amount up to a great deal, we have an exciting agenda lined up today. So you'll be hearing how Australia is overcoming cultural barriers to data collection through meaningful engagement with Aboriginal communities, how Norway's national data map turned data management from a challenge into the backbone of their health data success, how Canada is responding to public concern around trust, governance, and influence of American big tech. And all this will be knitted together through a keynote from former Chief Medical Information Officer for Portugal and Professor at the University Institute of Lisbon, Dr. Enrique Martins. I'm going to pass over to Enrique now. Enrique, I believe you're sharing your own slides, so I'll let that transition happen.
Thank you very much for having me, and let's go straight to our discussions today. I mean, one of the reasons why I'm talking to you from Brazil is exactly because the world is changing and the internet and all of this is now what we use to work and we assume it works all the time. And wouldn't it be great if we also assume that our health data also is available everywhere we go? And I think this is the ethos of what connects us all in this particular meeting. So, of course, these are some of the challenges that we will face. We will face challenges of digital inclusion. We will still face challenges of how to introduce telehealth in different services. But I'll jump these just to highlight that there's a reason why we're building these European health data spaces, these global data spaces, and that is to have better health for everyone, equitable, safe, efficient, patient-centered, timely, and effective. And we should never forget why we do these conversations and these discussions. Next slide. Over to health data. This slide is on purpose busy. It's just basically saying that everything is health data. And before we used to talk about structured data, unstructured data. You know, for example, you think about medication records or allergies, very structured, very organized data. And then you think about videos and tweets and things people say on the internet. And that also is becoming available to be analyzed by advanced algorithms of AI and others, and to produce meaningful insights into, for example, depression or mental health. So let's jump to the next slide to say that if so much data is available, how are we about sharing it? Well, we're very, very slow. This is a slide that brings us back almost 20 years of EU project collaborations as the basis for this European health data space. So this didn't come out of the blue. It didn't come because a bunch of regulators got together in the European Parliament and thought this was a good idea. It was the output of a lot of participation, patients, professionals, IT, standard development organizations, and also a voluntary collaboration that I was very proud to kick off a few years ago, and it is now covering more than 16 member states. We are already sharing data across countries in Europe, um, patient summaries and e-prescriptions. And this is a basis that allowed us to be confident enough to propose the regulation. So let's look at the regulation now. Next slide. So the regulation was proposed on May 2020, and that was May 22. 2 years after, we had a sort of COVID, really serious hit. And the COVID was the push for a conversation that had already been started. So in 2020, Europe thought, okay, the next big thing about, economic production is data. And it's the next set of rights have to do with data. And let's create data spaces. And many data spaces were outlined, but the first to be published and the first to be conceptualized were health. And that was quite amazing because normally health is behind many sectors like industry or aviation or other things. However, this meant that we looked at the European health data space at the time of the proposal as an ecosystem of rules, standards, and practices, infrastructures, and governance. So it's not a big database, okay, sitting somewhere in Europe or in Brussels. It is not. It is a set of things that we put together to realize this vision of data sharing. Let's move to the next slide. So in a nutshell, what is the European Health Data Space about? And as I say, what can it also be about? And because one of the challenges of today is, how can we collaborate? How can we think through and think beyond this work that, yes, is inspirational, but it doesn't cover all humans around the world. And for me, the passion is what could we do together to build a global health data space, as I call it, or maybe you can call it something else. It's fine. We can have a discussion on that on the Q&A. But how can third countries participate, not just in secondary use, but also in primary use? So let's understand what it is very quickly. Primary use is when, if I'm a doctor, as I am, and I'm looking at a patient, I'm typing in my computer what happened with him or her, that is primary use of health data. I'm using data to care at the point of care. Secondary use, I'm sitting in a research facility. I need data from all Portuguese people that have allergies with strawberries, like me, and have taken a drug that apparently works bad with people with strawberry allergy. And I want to know everyone about Europe that has allergies to strawberries and has taken this drug. Okay, and that's the question I ask, and I ask permit authorities to give me that information. I don't know who the people are. I don't even need to know who individually they are. So in secondary use, there is no name for the data. It is anonymous use, at least for now. And then requirements for electronic records. Why? Because if we don't build the systems according to the rules that we need so that the data can flow across the systems and also data can be extracted from IT systems, then the systems are not ready for use. So let's move over to the next slide. So as you can see, the European Health Data Space, which is a regulation in that sense, but of course opens doors to the building of infrastructures, creates rules for interaction and even training, is amazing in the set that it creates new rights, as I normally call them, these digital health rights. So in the EU, as per full implementation, which is May next year, citizens have the rights to these things, like accessing their health data, but also downloading a copy of the data, knowing who has accessed their data, but also set access restrictions. If I don't want a particular doctor or nurse to access my data, I can say so. And I can also opt out from data sharing if this is enabled by my member state. And I can insert information, which is a big, big topic. Not enough for today. Lucy, don't worry, I won't take over the entire webinar. But we can set up a webinar or two just on personal health data spaces. And that's my next passion now. But it's about how can we, as data producers about our own health, can participate in the data about ourselves. And this is really, really a game changer, not just technically, but in the terms of participation of citizens. How can I appoint someone to use my data because maybe I'm too sick to do that, and I might want to request a ratification. And we can also pick the data from one place and put it on another place. Next slide. For all of this to happen, we need what we call standards, and two types of standards happen to be developed. It's too techy. Okay, if you're curious about it, drop me an email and I will tell you about it. It's about interoperability, it's about logging, about knowing who saw what, who did what to my data. So let's move to the next one. Now, this is the busy one. So for the more techie people in the room, if you really want to know what is the exchange format about, it's all in Article 15 and related articles. But keep this idea. It's not closed. It's not closed. It is updatable, it is expandable, and it is automatable. So for those in companies, for example, listening to us, it might be interesting to know that all of this data has to be computer friendly so that we can use it and in different ways, including, of course, for AI, the big thing in the moment right now, but also that we can update this format. We can add more data sets. We can expand its use. Next slide. And then these are the timings. The only thing I want you to see in this slide is that the European Commission and the Parliament decided third countries connect as per 2037. I have to say I am very ashamed of this. I think it's one of the most sad things about this regulation is how on earth are we thinking about connecting only in 10 years' time, when today European citizens are moving to other countries and other countries' citizens are moving to the EU and bringing data with them. Honestly, there was a lot of resistance to thinking about connecting to third countries. So the fact that it is there opens the door. Okay, that's how positive we need to read it. But maybe we can try to, try hard to do some of these projects that I mentioned to you. So we can start now doing collaborative projects, and there are funding for that, and there are other legal means to do that, and that allow us to envision third countries participating much, much better, much more actively as we move ahead. Next slide. Yeah. So let's, can you just click all of them so in a row it's faster? So this is the journey if you're a researcher. If you're a researcher and you want to have access to data, remember the example I gave you about my strawberry allergy, and I want to know, okay, who are the people around Europe that have strawberry allergy? So I will ask, I file what we call a data request, and that goes to my national HDAP, so my health data access body, which grants permission. This permission can be shared only to my country, or it can actually go through other countries, and I get data from other countries. So this means that at the end, I can have data in a secure processing environment. This is a very busy word to mean an online cloud-based digital environment where the researcher can use the data without necessarily downloading the data to their computer and then using that data to produce his research. And then, of course, there's a right of publication, but there's also a duty of publishing results. So one of the interesting things about data permits is that they ask you why you're using the data, and you might be a research, you might be a pharma company, you might be an insurance company, okay? There's no restrictions. The restriction is about the purpose and about how careful are you with using this data. And then your commitment to publishing and bringing awareness about the findings of your. Next slide. Um, so how are we also in Europe preparing for this secondary use? Lucy already mentioned TEDA's project. TEDA's 2 is the sort of the follow-up from TEDA's 1. Both of them have to do with preparing the grounds, both technical, infrastructure, examples, and guidelines, especially on the area of secondary use. And you see many flags. This is the typical EU project, many countries, many languages. And, occasionally we find a way to work together. And now can you imagine, and that's my dream, could we have a project like this with flags from around the world, where we all would share ideas on how to share data and use it for research across the globe? I think that would be, sort of TEDx 3, maybe, or let's call it something else. Anyway, next slide. Now, to answer the challenge, how can we unlock pathways and paths for collaboration? So I think that there's several ways we can think about collaboration that will bring us all closer to what our challenge could be, sort of a joint goal, which is sort of global health data space. First is personalized health data engagement and mobility. Then let's think about circular use, and I'll cover what the concept is, but it's basically about using data for advancing AI developments and then reutilizing those insights into the care process. And then finally, looking at personal health data spaces is something that, well, in all due respect, all citizens of the world should have. And then slowly thinking what would be the technical basis, perhaps a global health record, of course, electronic by nature, to support a global health data space. So let's go to the next slide. So think about health data as something that you don't just use to see, you use to empower yourselves. So it's very important, and this is the work that, for example, Immune has been doing with her projects, and particularly with Gravitate Health. How can we use data to better understand my care? So, for example, I'll give you the example of self-management in terms of medication, diet, and adjusting myself on what I have to do to live well, for example, with diabetes and so on. And the thing is that when we move around the world, when not just Europe, but when we move around the world, we can use tools like the International Patient Summary, which is already available as a standard. But we are working, and there's one or two projects, some sponsored by the EU, others sponsored by WHO, on, for example, vaccination passports. But there's so many restrictions. So some are language. There are language choices that we need to be able to make. We should be able to understand, for example, a medication in our language. But if we buy a box of pills in another country, the inside box information often comes in the language of that country. So we need to free up data to make it multilingual multi-context so that every citizen can travel and feel secure. So let's go over to the next slide as an example. So remember that I mentioned to you that we were building, and we have built, connections between the EU countries to share e-prescriptions and e-dispensation. So as of today, a Finnish person can fly to the Canary Islands in Spain, somewhere in the Atlantic Ocean, and pick up their medication. But the box they buy of the medication will be written in Spanish, and the inside box information will be in Spanish. So, what are we doing, for example, with this project, Gravitate Health? And it will now move to a global center located in Oslo with the aim to promote these ideas across the globe. Gravitate Health was participated by countries such as US partners, Canadian partners. We had interactions with Japanese drug authorities. So it's not just an EU project. And of course, Pfizer, based in the main coordinator, one of the main coordinators, she was based in London. So keep this idea, very simple idea. You buy the box in another country, and rather than read the paper in a language you don't understand, you have an app. You have your national app or some other app that allows you a service. It's called the e-product information. Allows you to understand that product in the language of your choice. In this case, in Greek, Finnish, or whatever. Okay? So it's really about understanding that medication comes with information. You don't just take pills. You take pills, you need to be informed about them in order to take them safely. Next slide. Uh, yeah, so I told you about AI. I mean, I think there's no doubt. I recovered one of the first reports on AI, even before ChatGPT was even born or conceptualized, was actually from the UK, a very interesting report on how doctors and AI had to work together. But today, in today's world, I always give this example. Tonight, okay, every part of the world, doctors and patients will be using some sort of ChatGPT or Gemini or whatever to prepare for tomorrow's morning outpatient appointment. Doctors might be asking questions, what is the next approved treatment for this or that? And the same patient is going to be asking, oh, what should I ask my doctor if I have this and this? So actually, we are all using AI in different ways, and this becomes a new medical paradigm, but also a new patient paradigm. So we need to always remember that we have now AI powered patients and we have AI powered medicine to offer them. And these need to go hand in hand. Next slide. Um, so why do I bring this topic over? It's because most of the AI is developed outside the EU. Most AI models have been developed by companies outside the EU. However, for safe use of most of these insights, these AI models should use EU patient data. The reverse is true in other geographies. It's not a EU issue. Is that you shouldn't have an AI system developed in China, based used in Brazil, that has not been trained with Brazilian data sets. That is the way to, one, harm patients because insights are not going to be as accurate. And second, disrespect in a way, and I like to use this expression, disrespect local data symmetries that reflect local health practices and local health needs asymmetries. And there is no AI fits all models for the world. I don't believe in that. So what do we need to do? We need to use secondary use, perhaps anonymized, perhaps even non-anonymized. And this is an issue, a big issue. How can we convince people to do data donation, but even nominal data donation? I say the data, you can use my data even with my name on it, because I want to promote research. I want to promote that anyone with a rare disease such as mine, that everyone knows about, gets benefits out of that. And some people are very interested in doing that, so we should build infrastructures for that. The good news, the European Health Data Space was conceptualized to also contribute to AI development, AI support, and it, of course, as a regulation, connects with a so-called AI Act. Next slide. And I'm almost finishing, so I think I should be fine with time because we started a little bit later. But what is the final collaboration goal for me? And I've been moving around the world telling many people about this dream. Started writing about it in 2020, then 23, another paper, and so on. So today, another good opportunity. Have a quick read at the slide, but we can also discuss it later. Wouldn't it be great if, and as a clinician, I've been called to help people on a plane, that people on a plane can access your patient summary? And you don't need to give your data to the plane company. You can just open your patient summary access in the duration of the flight. When the plane takes off, it opens. When the plane lands, the software closes it down. And during the flight, if need be, certain people, flight attendants or whatever, can access it, and that will be recorded. Now, this is global thinking, and I think we can all be engaged in this. Now we can start with small things, global e-prescription, or maybe UK, EU e-prescription. We were there many years ago. The UK was working on e-prescription exchanges cross border. Now, temporarily, they're not in part of the roadmap, but that can be solved. It's a matter of us pushing it together. And the other thing is, when we talk about data sets and minimum data sets, that's my final word. We can move to the next slide. Is that humans are the same across the world biologically. So, I mean, yes, there's many political differences, there's many data differences, there's many infrastructure differences. But if we do knowledge and experience sharing as we're doing today, if we convince people to pilot across regions, and there are some examples I don't have time to go through, but there are some non-EU cross-border exchange piloting examples that we could tap on and continue and expand, we can create the necessary trust bases and, of course, develop the legal and organizational mechanisms for sharing. And I think this can be animated by global networks of who? Patient and patient data advocates and associations. I think it is the responsibility. Perhaps they're not equipped, at least in Portugal, they definitely are not. That I know because I've tried to help them. But patient, like understanding patient data and many others, I'm sure we can beef them up, give them the tools, and make them sit on the driving seat because it's patients' data that needs to go around the world to better patient care. And this is what I call digital health diplomacy. All these efforts put together. So I think that's my final one. I think the next one is just the Q&A one. I think yes, that is it. And if you want to follow the work my group is doing based in Lisbon, or you stop by Lisbon and visit us, but we're also around the world a little bit. Thank you very much, Lucy.
Brilliant. Thank you so much, Enrique, for such a clear presentation, such beautifully illustrated slides as well. If you haven't read Enrique's paper on digital health diplomacy, I highly encourage you to do so. It's very interesting. If you want to pop that link in the chat, Enrique, please do. Next up, we are moving over to lessons from Australia, overcoming cultural barriers. We have Dr. Daniel Armour, Senior Lecturer at the University of Queensland, and Dr. Ilan Mears, Programme Manager at the Australian Research Data Commons, taking us through their learnings today. Over to you both. Thank you very much.
Thank you, Lucy, for the kind introduction. Can everyone hear me okay?
Yeah, we can hear. Thanks, Ilan.
Great. So ARDC and its project partners from the University of Queensland are really grateful for the opportunity to speak today. And Danielle and I will be presenting on two projects that relate to Indigenous data governance for both administrative data and health data here in Australia. Next slide, please. So I'd like to start by acknowledging the Turrbal and Yagara people, the traditional owners of the lands on which I live and work, and I'm presenting from today. I pay my respects to elders past and present and recognise their continuing connection to land, waters and communities. Next slide, please. So a little bit about Australian Research Data Commons and our role here in Australia. We're the leading research data infrastructure capability, and our purpose is to provide Australian researchers with a competitive advantage through data. And next slide, please. So within our organisational strategy, we seek to realise this goal through our Research Data Commons approach. Similar to the concept of a Creative Commons, at ARDC, we're dedicated to building and nurturing a collective commons of shared knowledge and infrastructure that powers world-class data-intensive research and innovation nationally within Australia. And today, Danielle and I are both focusing on data governance, which we would consider to be a core piece of socio-technical data infrastructure within our commons framework. Next slide, please. So we have 3 thematic research data commons: people, which supports health and medical research; planet, which supports our environment and earth science research; and our humanities, arts, social science, and Indigenous data commons. And so I am here representing People RDC, and Danielle is going to tell you a little bit about a project that is being supported out of our HAS and Indigenous data commons. Next slide, please. And I'll hand over to Danielle now.
Thanks, Elan. Before I start, as part of Aboriginal protocol, I'd like to introduce myself. As Elan said, my name is Danielle Armour, and I'm a Kamilaroi woman from northern New South Wales. My cultural connections are through my paternal lineage, and I'm a senior lecturer at UQ, as you heard in the introduction. But I'm also the co-lead on the Social Science Research Infrastructure Network project, which partners with the ARDC. I would like to acknowledge the traditional custodians of the land on which I'm meeting today, the Gidja people. I thank them for having me here in Punalulu, which means sandstone in Gidja language. I'm speaking to you today from Punalulu. I'm speaking to you today from the Kimberleys in very remote northern Western Australia. I acknowledge and pay my respects to my elders past and present, and thank them for paving the way for Aboriginal and Torres Strait Islander peoples. And I also acknowledge any Indigenous peoples here today. Just for those that are unfamiliar with Australia's Indigenous peoples, Aboriginal and Torres Strait Islander peoples are actually 2 distinct groups of peoples that are made up of many different cultural practices, languages, and knowledges in those 2 groups. But we are put under the one umbrella of Indigenous peoples, even though we're 2 different groups of peoples. So the Social Science Research Infrastructure Network, which is a mouthful, or SSRIN, is a national initiative in Australia designed to strengthen the use of linked admin data and research data across the social sciences. Its goal is to improve how data is accessed and governed and used to generate evidence that informs policy, social research, and community outcomes. Social Science Research Infrastructure Network brings together government agencies, researchers, and data users to build coordinated, ethical, and high-quality data infrastructure, particularly around linked administrative data sets. There are 5 streams within the project, and I'm the co-lead of Stream 3.5 with Professor Francis Mitro from the University of WA. The focus of this stream is the development of national Indigenous data guidelines. The aims of this stream are to establish consistent national guidance and for the ethical use of Indigenous administrative data for Indigenous peoples. It's also to embed Indigenous data sovereignty principles, including governance control and interpretation of data, to improve the quality, consistency, and cultural safety of Indigenous data in government systems, and ensure data is used in strengths-based ways that benefits Indigenous communities rather than reinforcing deficit-focused narratives. Stream 3.5 recognises that data about Aboriginal and Torres Strait Islander peoples is not just technical infrastructure, it is culturally, ethically, and politically significant. Historically, Indigenous data has often been used in deficit ways, framing Indigenous people as the problem rather than recognising the structural and systemic factors shaping outcomes. This has limited the value of data and in many cases caused real harm. The history is a key reason why developing the Indigenous data guidelines are so important. Next slide, please. While today's discussion focuses on patient health, I want to briefly share the approach we are taking in developing Indigenous data guidelines within SSRIN, as these processes have broader relevance. At its core, this work recognises that data is not just a resource to be managed, but something that is owned and connected to people. Today, I'll focus specifically on the governance structure we used in the project. In developing the guidelines, we're drawing on established frameworks, including the FAIR and CARE principles, the IEEE recommended practice for provenance of Indigenous peoples data, and the Cancer Australia data framework, among others. We are intentionally aligning with multiple frameworks and to ensure consistency with best practice, while also aiming to go further by creating a gold standard set of guidelines that provides a clear benchmark and assurance. The process we use offers relevant lessons for initiatives such as the European Health Data Space. In particular, it demonstrates the importance of embedding data custodians and including patients and communities in decisions about how data is assessed, used, and governed. This shifts the perspectives from people as passive data subjects to recognising them as active stakeholders within ongoing rights and interests in their data. To operationalise this, the SSRIN uses a dual governance approach, and we are very aware of the cultural load carried by Aboriginal and Torres Strait Islander people in governance roles. However, we felt it was essential that Indigenous voices be heard from multiple levels and places. Next slide, please. You can see on the screen there's 3 definitions that you'll hear a lot about today. I know we've been using, in our policy, we use Indigenous, so hence why Indigenous is used, but in Australia, often First Nations is used as well. Next slide, please. First, we established an Indigenous steering committee. This group includes Aboriginal and Torres Strait Islander experts from universities, governments, organisations, and non-government organisations who work closely with large data sets. They provide cultural authority, technical and expertise, and strategic guidance to shape the guidelines. Second, we formed a community reference group made up of grassroots community members. Their role is equally important. They focus on accessibility, transparency, and understanding, ensuring the guidelines are meaningful, culturally appropriate, and reflect community expectations. Together, these 2 groups ensure the guidelines are both technically robust and grounded in lived experience. I want to note that while we prefer face-to-face engagement, this is not always possible. Australia's large. I'm 8 hours away from a 6-hour flight away from home at the moment. We meet online, which can mean relationship building takes longer, particularly within the community reference group. It is also important to recognise that Aboriginal and Torres Strait Islander peoples are not a homogenous group. The different colours you see on the map of Australia represent that we are all different countries, each with distinct languages, cultural beliefs, and worldviews, a bit similar to Europe. This layered governance model creates an ongoing Facebook loop between expert knowledge and community insight. It strengthens trust, accountability, and transparency that are just not ideals, but practical necessities for responsible data use. This approach also offers important lessons for initiatives like the European Health Data Space. There have been challenges. Ensuring representation across metropolitan, rural, remote, and very remote communities requires significant coordination, flexibility, and resourcing. Ethics approval processes are complex. For example, attaining university ethics approval for the community reference group took approximately 3 months, which was essential given the project will include a pilot phase. That pilot phase adds complexity, but also opportunity. We are working with the Australian Bureau of Statistics to trial the guidelines in a real-world setting and gather feedback from end users. Balancing institutional timelines, community expectations, and technical feasibility requires careful facilitation. What we have built through SSRIN is not just a governance structure, it represents a fundamental shift in how data is understood. Rather than viewing data as neutral, this work recognises that data is connected to people, identity, community, and lived experience. And because of that, data governance must centre relationships, responsibility, and accountability. Next slide, please. What SSRIN adds is operationalisation, how these principles actually work in practice, governance mechanisms that embed care, collective benefit, authority to control, responsibilities, and ethics. And what our work shows is that good data governance is not just about standards, systems, or legislation. It's about relationships, responsibility, and recognising that data is connected to people. The SSRIN model demonstrates that governance includes both technical expertise and community authority, we get data systems that are not only more ethical but also more effective. And these are lessons that extend beyond First Nations data in Australia, but worldwide, where trust, participation, and accountability will ultimately determine success. There are several key lessons from this work that extend beyond Indigenous data in Australia. First, we need to move from seeing people as data subjects to recognising them as data stakeholders. Second, governance must be layered, not singular. Technical expertise and community authority must work together. Third, trust is built through process, not just policy. Fourth, data is cultural, not just technical. Fifth, co-design improves both ethics and data quality. Sixth, representation requires genuine resourcing and flexibility. Seventh, there must be a shift from deficit-based to strengths-based data use. And finally, the principles like fair and care must be operationalized and not just referenced. What SSRIN demonstrates is that good data principles, that good data government is not only about systems, standards, or legislation, it's about relationships and recognizing that data is connected to people. When governance includes both technical expertise and community authority, we create data systems that are not only more ethical, but also more effective. These lessons are not only relevant in Australia, but globally, wherever trust, participation, and accountability will determine the success of data systems. And I'll just hand back over to Ilan there.
And one more slide forward, thanks. Amazing, thank you. Thank you so much, Danielle, for sharing all of your insights from the SSIRN project. I'd really like to follow on from you and really talk through why the SSIRN project's work is so transferable to the work that we're doing in the harmonisation of health data across jurisdictional borders here in Australia, which we're doing through our People Research Data Commons. Next slide, please. And so by way of background, I just wanted to briefly touch on the policy landscape for secondary use here in Australia. It's a fairly favourable policy landscape. You have to meet the requirements that we have on the slide in order for secondary use to be granted. This is generally around health data obtained at point of care or administrative health data. And we also have a national consumer controlled health information repository called My Health Record, where the patient's health information can follow them between providers and across Australian jurisdictional borders, very similar to the My Health at EU initiative. And it's currently under consideration whether secondary use of that data asset should be made available for research and public health purposes. Next slide, please. Another really important policy development that I thought I would touch on, given the context of this presentation, is recent commitments in our national health reform. So the Australian and federal state governments substantially strengthened our national commitment as a country in March this year to the full realisation of Aboriginal and Torres Strait Islander data sovereignty. And they include the following commitments: that Aboriginal and Torres Strait Islander people should exercise control of the health data ecosystem, that their health data should be contextual and disaggregated, it should be relevant and usable, that health data structures should be accountable to Aboriginal and Torres Strait Islander people and community-controlled entities, and that data should be protective and respect Aboriginal and Torres Strait Islander people's individual and collective interests. Next slide, please. And so these commitments to embedding Indigenous data governance and sovereignty are really important in the work that we're undertaking nationally to harmonise healthcare data to the OMOP Common Data Model. And this is where we're converting electronic hospital records and a range of health administrative data sets to the OMOP Common Data Model. And in a shameless homage to the European Health Data and Evidence Network, we've launched the equivalent initiative here in Australia, if you're familiar with the OMOP landscape in Europe. Next slide, please. So we have chosen to invest and back the OMOP Common Data Model here in Australia for secondary use. Due to its growing use in 80 countries worldwide and capture of at least 12% of the world's population, we further believe that OMOP federated analytics, where only de-identified summary statistics, offer a significantly lower risk profile, and they expedite data sharing between organizations when compared to sharing or accessing unit record data. And lastly, the Odyssey community's standardized conventions and tooling and culture of sharing reusable analytics improves scientific rigor, fosters collaboration, and reduces bespoke cost and effort. Next slide, please. However, dovetailing Indigenous data governance and sovereignty principles with the OMOP Common Data Model is not without its challenges, where in particular in our Australian context, there's currently no standard or culturally approved way to represent Aboriginal or Torres Strait Islander identity and OMOP. And so we are currently embarking on a careful scoping process to determine how care and Indigenous data governance and sovereignty principles should be applied consistently when population electronic medical record data is converted and harmonized to the OMOP Common Data Model, and how OMOP data about First Nations people should be managed in ways that support self-determination, benefit sharing, and long-term trust, and most importantly, lead to better health outcomes for Australia's First Peoples. And in this process, we see ARDC's role is to empower and support First Nations leadership to undertake this work, to determine culturally respectful and safe practices that are community endorsed, as Danielle mentioned, and connect First Nations leadership with motivated health service and data partners to begin to operationalize best practice in this space. And you can see that in this work, we're incredibly fortunate to be able to learn from the SSIRN project and all of the principles that Danielle has shared with us today. And next slide, please. And that's where I'm going to finish up in the interest of time. Thanks so much for your attention. And if you'd like to learn more about our work and our projects, please get in touch.
Brilliant. Thank you so much, Danielle and Ilan, for sharing your work with Indigenous communities and how that is translating across to your data governance structures too. A lot of learnings that can be translated to different data networks, I'm sure. We're now handing over to Susanna Nordeng. Next slide, please, Nadia. Thank you. Who is the Senior Advisor and Metadata Manager at the Norwegian Public Health Institute. And she'll be sharing lessons from Norway, the map that helps us navigate health data. Susanna, over to you.
Thank you very much. We can, we can start. I can say that I would like to say thank you to inviting us to present our field and implementation of the EHDS in Norway from the metadata perspective. Yes, why metadata? Metadata is a foundation of the European health data space, and it's very important with relation to the FAIR data when one applies for metadata. This is the field of the secondary use of metadata. So where maybe the patient is in the focus with relation to research, policy making, and innovations. And when we talk about operationalizing metadata, we are talking about making data, health data, findable, accessible, interoperable, and reusable. This is very important in order to reuse data and reuse them in a proper way. We can go to the next slide. How metadata were evolving in Norway? Norway is I would say a country that has a lot of health data that are existing in health registries. They are existing in universities, and as Henrik said earlier, they are everywhere. And how to find them? Well, we need to have a well-organized and good quality of metadata. And that's something that we are very concerned of. we as our institute, we are a data holder of let's say the most health data related to healthcare. In other words, we talk about the elementary health registers related to birth they follow patients from birth to death, and they cover also the main chronic diseases, as are the heart diseases, cardiovascular diseases, and cancer. What is also very important to point is that Norway has a very strong legal frameworks that are important in provision of the health data, and it was not easy to do this journey in order to collect the metadata in one place from all registries or from the main registries in Norway. And one of the incentives to provide the metadata and standardize them was to give a bit of carrots to these registries, especially the registries that are having focus on the quality of the healthcare. We can go to the next slide. What was the response in order to develop the metadata field in Norway? One of the things that should get special focus is the national metadata specifications that have been evolved in last 8 years, and they are forming the import or the delivery of the metadata from all registries to us as a metadata administrator, and also delivering it to portals that are providing information about the health registries and the data sets for use of secondary use. We have also in the last 7 years developed a portal, health data portal, that is like a one-way stop in order to apply for health data, that I may show you a short demo later. And we also started to develop a national metadata management system that is a repository for metadata, for all metadata in Norway. And this project started last year, so we are still in a first phase, and the interface has been only recently developed, so I'm not 100% sure if I show you the demo for that. But we can go to the next slide. I already mentioned the national specification of metadata, so we can go to the demo. I will try to share and show you a little bit more about the health data. If you are interested in our national metadata specifications, you can reach it and consult afterwards. So I'll share my screen. Can you see? Yes, well, I cannot hear anybody, but
Sorry, Susanna, we can't see that just yet.
Oh, you cannot see. Okay. No. Well, maybe I have to click on one button. There are too many buttons to click on to get through.
There you go. We can see that now.
Yes, can you see? Yeah. Well, just very quickly to follow the timeline. This is health data. It's now in the Norwegian, which is the language that is normally used to apply for health data. In the same time, we get applications for health data from international researchers through national research applications. So we have partly also our website or the health data platform in English. And quickly, I can show you that we have something that is called data sources, or it's a data source explorer, where you can find information of all registries that we host, and you can also find information about how you can apply for data, and what kind of variables we have, you can go straight to variable explorer, what kind of variables we host under this registry, what kind of data, well, in a way, the data collections or data sets we host under the cancer registry. As you can see, this is in Norwegian, and we can hope that in the near future it is going to be also not translated, but put into production from our IT team. We have also dividing the variables in the variable groups, and also there are other features like the temporal coverage, and also the common standard vocabulary. And also we have a part that is related to the data applications, where you can create your own data variable list. So you can choose the codes and many more. I think I can quickly go to next slides to I can stop sharing. This was like just an appetizer, and I encourage you to have a look later if you find time. So I'll stop sharing. Because I cannot show you Munin, it's still loading, but I can show it to you on the slides. So if it's possible we can come back to the presentation. The slides that are black. Yes, here the slides we can go quickly through. I don't have to present them. I put them just to give a little bit of information for those who would like to have a look later, if you are going to share the presentations. And I can quickly say a little bit about Munin. So now I showed you health data. So it's kind of, as I said, one shop or one-step shop where you can find metadata, and you can make your variable lists. You can apply for metadata, apply for health data through picking the metadata, and also create your application for health data. So this is something that is publicly accessible. Munin, it's a data management system or metadata management system. So this is a back office of metadata management. So this is something that it's not public, and it's a repository for metadata for all metadata in Norway. That's the plan in order to implement the European health data space. And we have started last year, so it's still under the implementation. And recently we have developed the interface, so I can show you a little bit. And this is the first page, which is actually describing the import of metadata, the batches, it's quality assurance of metadata, and data sources, where we have a data source catalog with data sources and metadata that are partly also in line with EHDS. We can go to the next slide. This is the interface of how we can upload metadata. So for the moment, we can upload in the zip file in the Excel format. And we have already created APIs in order to import data in the machine readable format. We can go to the next slide. Here is the interface for the metadata care. You see the several status where we can see that the metadata that were imported are not in line with our metadata specifications. So they are going to be rejected, and they have to be corrected and sent back to the registries. There are metadata they are already validated, and metadata they are already accepted. We can go to the next slide. Here is a data source catalog, which is describing the metadata of each data source that is in our metadata repository. And also we are in the process of being harmonizing us with the EU metadata standards. This is called EHDS, and in the upcoming years, we will not be only 44% compatible, but 100%. We can go to the next slide. Yes, this is inside of the data source. So these are the metadatas, and you can see that we are partly in line with the description of the data sets. We can go to the next slide. Yes. Yes. What it means metadata in everyday work. That's what is important to say, that we prepare metadata to be used for research, for better healthcare, for policy making and innovations. So in practice, this means that users can explore metadata first, understand data sets or data collections, and submit better targeted applications. So this will lead to better data services, and also it will reduce manual clarifications and speeds up the processing. We can go to the next slide. Governance and sustainability. Metadata governance is data governance. For us, it's very important that we are the main health data access body, and we can nationally coordinate the essential part of responsibility that should be shared across organizations. So sustainable metadata work requires clear rules, skills, and long-term resourcing. So when we talk about the metadata managers or metadata people, we talk about transdisciplinary teams, which are representing people from data science, IT solutions architectures, maybe also health personnel that are, for example, nurses that are collecting metadata at hospitals, to actually people who are focusing on policy making and ensuring political will. We can go to the next slide. How we are preparing for EHDS. For us, the interoperability is very important. So as it was already described, we are preparing to be compatible with EHDS standard. We would like to ensure cross-border discovery, so harmonize metadata with other countries. We are in several projects that are working on networking and building and preparing for EHDS. And we are also focusing from national metadata management to European metadata management. We can go to the next slide. So what are the lessons learned? For us, we learned that we need to start with user. We need to explore what our users need in order to prepare better metadata catalog where, for example, researchers can apply for health data. So the collaboration is very important. What is also important to say that we have to have legal structures that are also making things possible and not making things impossible. It's important to not wait, but start doing things. It's better to make mistakes and correct it than wait till it's too late and accept the revolution, because all the standards are evolving and we need to just follow the trends and adapt. Yes, that's next slide. I can say thank you. I hope I didn't take too much time and I didn't go too much overtime. And if you would like to reach me, you see my email address. Thank you.
Brilliant. Thank you very much, Susanna, for taking us through Norway's metadata progress. Really interesting, and I'm sure you have some people who want to explore that platform further. Now delighted to hand over to Catherine Street, who is the Public Engagement Executive Lead at Health Data Research Network Canada. Catherine will be sharing lessons from Canada, public views on trust and acceptable health data use. Thank you very much, Catherine.
Hi, Lucy. Hi, everybody. Thanks for that kind introduction, and thank you for inviting me to speak today. As you can tell from my accent, I'm not Canadian. I was born in the UK in Birmingham and worked with the NHS from 1990 to 2004. So it's a real treat to be back in the UK presenting. Next slide, please. I'm actually presenting from a small community called Borleen in just outside St John's in Newfoundland and Labrador. And in the spirit of truth and reconciliation with our Indigenous partners, I respectfully acknowledge that the land on which I am presenting from today is on the traditional territories of the Beothuk. Today, these lands are home to a diverse population of Indigenous and other peoples. I would also like to acknowledge with respect the diverse histories and cultures of the Mi'kmaq, Innu, Inuit and South Inuit of this province. And the photograph on the slide there is the view from my window just here at sunset. Slightly different from inner city Birmingham. So before starting, I'd like to just quickly acknowledge our funders, CIHR, who are our main funder, PHAC, who funded two of the projects I talk about, the team that work around us, including our spectacular Public Advisory Council, the participants of focus groups and interviews, and the wonderful team that I manage, the Public Engagement Coordinating Team. So a little bit about Health Data Research Network Canada, which I'll just call HDRN for now to keep things moving. So our first 7 years of funding was awarded by CIHR, our funder, in 2019, and we've just been renewed for a further 2 years. The mission of HDRN is to bring together data centres from across Canada to facilitate transformative and world-leading health data use. Our vision is to drive improvements in health and health equity through effective use of data held in the provinces and territories of Canada. Our key values are those which any organisation should have: collaboration, trust, creativity, excellence and respect. We also, of course, believe that the public should be actively engaged in all elements of our work. The focus of public engagement is clearly demonstrated in our strategic framework through our strategic goal of ensuring purposeful and ongoing public and community involvement. Next slide, please. So my presentation today will outline Canadian public views on trust, acceptable health data use, and the presentation will be broken down into 3 elements: social license, public trust literacy and health data, and some information on American big tech and the relationship with Canada. So, over the last decade, research has found public support for health data being used for public benefit when concerns related to privacy, commercial motives, equity, and fairness are addressed. The Public Health Agency of Canada contracted with HDRN Canada to build on this body of research by adding in some new elements. These included the views of experienced public and patient advisors about essential requirements for a use or user of health data to be within social license, specific examples of health data uses and users that participants agreed are within or outside of social license, and the views of individuals who have different needs and expectations than most other people, as these views may not have been captured in previous reports that focused on identifying major themes and majority views. I'll just note that for all of my slides, if there is a relevant publication, it's referenced at the bottom, so you can see the publication reference there. Next slide, please. So how did we capture perspectives of these experienced patient and public advisors? We focused our work on inclusive design to identify minority views on essential requirements for health data social license. Now, I know minority is used in all kinds of ways. So when I state minority, I mean in a purely numerical sense based on participant responses. So people who hold these minority views are often the ones least likely to be well served within the status quo, and also often holders of knowledge that work for the entire population, not just the majority. And as a result of including these minority views, our finding includes views and requirements that were perhaps only supported by 1 or 2 of the participants involved in the study. Our method of facilitated dialogue also ensured that participants had the opportunity to share their views, listen to each other, and if necessary, change their minds. Our five-fingered facilitation technique was used to help participants move to consensus on examples of what is within or not within social license. This method involves non-binary versus yes or no, real-time voting to support consensus building. And if you need more information on the five-fingered facilitation method, we can cover that in the Q&A. So what did we find out? We found out that 20 advisors had very different views about what constitutes an essential requirement for health data use or user to be within social license. And actually, by the end of the process, our participants had generated a list of 85 essential requirements for things to be within social license, which was much greater than the smaller list of about 16 that we started with. So despite not reaching agreement about the essential requirements for what is within social license, they did agree that it is within social license for health data to be used by healthcare practitioners to directly improve healthcare decisions and about the services provided to a patient. It's within social license for governments, healthcare facilities, or health system administrators to use data to understand and improve healthcare and the healthcare system. And it's also within social license for university-based researchers to use data to understand the drivers of disease and well-being. As noted, there was not consensus on the essential requirements for something to be within social license, and as a result, it was not possible to make statements about what is not within social license. But two examples were agreed upon, and I don't think you'll be surprised. It's not within social license for someone or some organisation to sell or resell someone else's identified health data, nor is it within social license for health data to be used for a purpose that does not have patient, public, or societal benefit. Next slide, please. So this work that I've outlined is specific to Canada, and it's important that each country does their own work, as there will be differences. This became clear to HDRN when we discussed our findings with colleagues from Australia from the Population Health Research Network, who completed a similar study, and their results were different from ours. As there were differences in these results, we did host two joint webinars, one for Australia, one for Canada, about the differences between our research, and these can be found online, and I can share the links. In addition, we also hosted a workshop at the 2024 International Population Data Linkage Network, I always struggle with that, conference in which we discussed the drifts and shifts in social license. A social license isn't static. It is impacted by events such as the geopolitical situation, local and national data breaches, changing government, and public trust. Next slide, please. That moves me into the second part of my presentation about public trust. Next slide, please. Public trust in governments, organisations, and institutions that collect, protect, share, and use health data is critical. Access to timely and reliable health data is the foundation for providing high-quality healthcare services and public health services. Access to health data is also critical for health system planning, management, evaluation, research, and innovation. These uses often involve combining or linking data sets, so data linkage, and can also involve interest from the public, non-profit, and private sectors. So trust is essential. Now, due to the importance of trust, the Public Health Agency of Canada commissioned our team to create a document to help different levels of government and health system organisations work together to earn public trust in and public trust regarding the understanding of health data. Next slide, please. Before we could create a foundational paper on trust, of course, we needed to understand what trust is. There's no single broadly accepted definition of trust, but it is understood to be important in areas of relationships where there is risk, uncertainty, and interdependence. Trust can be thought of as one of the interpersonal attitudes required when a person is dependent upon another to achieve some goal under conditions of uncertainty. It is also important to understand the differences between trust and other related concepts, such as reliance, confidence, dependence, or obligation. This conceptual distinction is critical if we are to understand and respond to the challenges of trust. For example, there is a difference between reliance, I rely on my doctor to give me the right prescription, or credibility, I think that person knows what they're talking about, or trust, I trust my colleagues to have my best interests at heart. If or when trust is relational, it also needs to be reciprocal. So it's not just about people trusting organizations. In equal measures, organizations and institutions must demonstrate that they trust people. Trust can't be demanded or expected. It's earned through trustworthy practices and behavior. And rather than think that it is worked on directly. Both reliance and relational aspects of trust are important, but health data is important for health and health data as a way for institutions and organizations to demonstrate that they are trustworthy. In some cases, it says that trust is slow to be developed, but very, very quick to lose. Comes on a tortoise, leaves on the back of a horse. So, our original brief for this piece of work was, and I really do paraphrase here, tell us how to increase health data literacy to the public so the public will trust us. As I'm sure you know, that's not the way it works. Taken together, the evidence suggests that health data literacy is essential for helping individuals and organizations make informed decisions about their health, healthcare, and health data. But the greater the health data literacy may not inherently increase trust. Health data literacy should rather be viewed as one of the several foundational elements that create the possibility for trust, alongside other key factors such as transparency and public benefit. Next slide, please. So what did we find? What are our recommendations? We put forward 6 recommendations as to how people and organizations may demonstrate or develop trustworthy data practice. I'm not going to go into them in detail, but they were, and you'll not be surprised by this, organize ongoing inclusive public engagement. Prioritizing inclusive ongoing public engagement requires aligning engagement approaches with objectives. I'm sure you all know about the International Association for Public Participation Framework, and that it emphasizes engagement at all levels, if possible. Of more relevance to Australia and Canada for the 2 countries represented here, support reconciliation and respect and support Indigenous data sovereignty. It is vital that we work with Indigenous partners and build and ensure that we are seen as trustworthy and we earn their trust. Create clear rules and supports for data sharing, access and use. We've talked already about principles and frameworks such as FAIR, and another one would be the 5 safes, but these are only a guide to practice. Policies and processes are what give life to principles in any institution. Clearly written policies then make it possible to be transparent about practices. And our last 3 recommendations were: ensure health data use aligns with public benefit. And one way to do that is to ensure that you involve members of the public in setting guidelines and guardrails. Create technology standards that will make data safe and sharing seamless. Now, I was quite jealous in the first presentation when we talked about interoperability of data within the European health data space. Within Canada, we still have a clear need for common interoperability standards, as these define the safe technological methods by which we can share data across provinces and territories, something we can't currently do. And also be transparent and create opportunities for reciprocal learning. So those are our recommendations for trust, for developing trustworthy data practices. And that then leads me on to American big tech and data infrastructure. I did kind of smile when I had to make that leap. So if we can move on to the slide geopolitical situation, please, that would be great. So before starting this section of the presentation, I need to clarify that we have not undertaken detailed research on this area in terms of the impact of American big tech data infrastructures on trust. This information I'm providing now is really common knowledge in Canada and some information collected through a very brief literature search. In many provinces, trust in the US has declined, and this is mainly due to what I'm going to kind of jokingly refer to as the Trump effect, and President Trump's stated wish to make Canada the 51st state of the United States of America. If that happens, I will be straight on the plane back to the UK. So this in turn, many have reacted like me, and this in turn has resulted in a movement called Canada Strong, the objective of which is to unite Canadians to secure our sovereignty and our economy, and also protect Canadian values and build Canada to be the strongest economy in the G7. My apologies to other members of the G7 at this presentation. So since the inception of Canada Strong, surveys have indicated that trust in governments has risen to 40%, up from 36% in 2025 and 32% in 2021. Institutional trust is rising overall, but trust in big business, often linked to big tech, remains low or is worsening. Overall, over 75% of Canadians do not see the US as a trustworthy ally. But what does the Canada Strong movement mean for digital services in Canada and health data in particularly? Unfortunately, within Canada, due to our long-standing relationships with the States, we have a heavy reliance on US-based cloud infrastructure and big tech firms. And our reliance on US-owned cloud infrastructure creates a structural gap between where data is stored and who controls it. This gap introduces security and geopolitical risks and ultimately undermines data sovereignty and public trust. The Cloud Act, the long name being Clarifying Lawful Overseas Use of Data, enacted in 2018 in the US, explicitly grants US federal law enforcement the authority to compel US-based technological companies to provide requested data. The mandate applies irrespective of where the data is physically stored within the United States or on foreign soil. Consequently, if a Canadian business utilizes a cloud service owned by an American company, the data could be legally accessed by US authorities without the Canadian entity's consent or even its knowledge. This situation highlights a critical disconnect between the physical location of data, where, while important for residency, does not inherently determine its legal governance. The true determinant of data sovereignty is the legal jurisdiction in which the cloud provider is subject. Now, this article notes growing concern, the article referenced below, notes growing concern among Canadians about how their data is handled, and if data is exposed to foreign control, trust in organizations and systems decline. We also have the added problem of tariffs. And I have to be honest, tariffs change so often, I've lost track of them. But what you really need to know is that the tariffs, even if it's a 10% UF tariff, could reduce trade volumes between the US and Canada, lower productivity, and decrease real income in both Canada and the US, which of course has a dramatic impact. So what does all of this mean for health data? What can Canada do to protect its health data? The obvious approach would be for us to move away from having any infrastructure within the States and to build our own infrastructure. But many of you work within health data, so I'm sure you're very aware that it takes a long time to build that infrastructure and it's expensive, and tariffs are just adding to that problem. So to begin to address the problem, the government of Canada has adopted a cloud-first strategy. But as I've already explained, if it's an American cloud, we still have problems because it is the data within that cloud is under the legal act of the Cloud Act and therefore accessible by US companies. So a white paper has been produced which suggests an approach to the management of data in foreign companies. It starts by identifying the three core challenges which I've mentioned: data security, residency, and sovereignty, but it then proposes a way to address these challenges and reduce the associated risks. So in terms of security, limit what data goes to the cloud. Don't put very sensitive health data on the cloud. Encryption, ensure that data is encrypted in transit and is encrypted at rest, and only Canadian government retains the control of the encryption keys. So even if it's accessed by a US organization or government, it can't be read. And contractual procedures require providers to disclose any unauthorized access or indeed any legal requests under the Cloud Act. So in summary, Canada operates in a global, interconnected digital ecosystem, and complete data sovereignty is difficult to achieve, and global interdependence is unavoidable. We can't be an island. But hopefully the measures recommended in the white paper referenced on the slide will go some way to protecting Canadian data and ensuring Canadian access and maintaining public trust. And interestingly, just when I was writing this presentation, Mark Carney, who many of you in the UK know is the previous Bank of England governor, actually announced significant funding for the Canada Strong movement to ensure that we are able to build the infrastructure that we need to reduce our reliance on our neighbour to the south. Thank you.
Brilliant. Thank you so much, Catherine. I'm sure some of the messages that you shared in there regarding public trust and American big tech will feel quite pertinent to our attendees over in the UK today as well. So let's move quickly on to our Q&A. We are running a little bit behind, so we'll probably won't have as long, but please do start popping your questions in the chat for our speakers today. As a reminder of who we have present, we've got Dr. Enrique Martins, the former Chief Medical Information Officer for Portugal and Professor at University Institute of Lisbon, Dr. Ilan Mears, Programme Manager at the Australian Research Data Commons, Susanna Nordeng, Senior Advisor and Metadata Manager at the Norwegian Public Health Institute, and Catherine Street, Public Engagement Executive Lead at Health Data Research Network Canada. We've got a couple of questions to get us started for the Q&A, which I'd like to present to all of our speakers today. Quite a broad one to kick us off. What is the key benefit of joining the European health data space for third countries, non-EU countries? Who would like to get us started on this one?
I think for Canada, the key advantage at the moment, although you say it'll be 2037, which is a bit of a long run-in, but we can learn from you. Currently, health data is managed independently across the 10 provinces of Canada. So from west to east, we have 10 provinces and we have 3 territories. The territories and the provinces do work slightly together, but our data is managed independently. So at the moment, it is not interoperable between the provinces and the territories and cannot be shared across geographical boundaries in an identifiable format. So say I had to move from Newfoundland and Labrador to British Columbia on the other side of the country, my data would not automatically transfer with me. So I think we can learn a lot from what Europe is doing. There is some hope on the horizon for Canada. There is a new bill, Bill S5, which is called Connected Care for Canadians, which aims to address the issue of sharing data for care and also for secondary uses for research across those boundaries. So I am hoping that that bill, when it becomes an act, will move us in the correct direction. But until then, I think we really need to see what is happening within Europe. And also, as I mentioned, we are moving away from our reliance of the States and trying to work more closely with the rest of Europe and other countries. And I think looking at your learning from the European Health Data system would help us in also aligning ourselves better with Europe and other countries. So thank you.
Brilliant. Thank you, Catherine. Really interesting to hear how it affects Canada, especially in relation to your relationship with the States and moving over to more European relationships too. Enrique, did you want to come in here?
So I took out my camera because of bandwidth. Quick reactions. First is, for example, Canada, but not just Canada, Korea, and this year, recently Japan, institutions can participate in Horizon Europe funded projects, of course, the UK as well. And I think this is information for everyone, because on the way the legal and the solutions that were found, of course, to be adapted in different contexts, and that is transferable today. You don't have to wait until 2037. That is project connections, establish also ways of understanding how you can build this trust and how you can this confidence. And since I sense a little bit of a nationalism and issues, and I even I talked about data sovereignty in the first slide. I mean, I think it would be good to remind us all that this project is a European project. So I mean, it might take some time in other areas, but even in different contexts, we have managed to find solutions beyond the politics. I think it's important for the healthcare people to try to find bridges where otherwise there could be walls. And then the final idea is, for example, in Korea, they admittedly say that they are working on a Korean health data space. I wouldn't say copycatting, but inspired on the ideas. And I think that's exactly what I think is useful. And I want to say also, in the interest of everyone, that many of the things that we put on our thinking as we were designing, and I was part of it since, well, I would say almost day one. The first workshop on the European health data space was in Lisbon. We also took ideas from other countries, non-EU. So it's not a sort of Europe-born for the world thing. It's also, we took a lot of inspiration from others. I remember reading and suggesting things that we saw that were already starting to happen in Australia, for example, the national provinces and things like that. So I think it's important to recognize that today the topic is European as a center for a broader discussion, but we don't need to have it as centered around that. It's centered around the principles. And I think I really liked, I don't remember exactly the name, you told about social contract, social license. It's this idea of social license, but we also use these common licensing models for documents, for example. So these are sort of common concepts to which we see most people in different countries around the world gravitate, even when their governments change more to one direction or to another direction. There seems to be a sort of a stable ground on the issues of, I believe, on the issues of what is trustworthy behavior by large institutions, what is not, and how individuals can benefit and what they participate with.
Thank you. Thanks, Enrique. So just because you broke up a little bit there, just to reiterate, so making the most of opportunities that are already out there, such as Horizon Europe, and looking outside the box of the EHDS and sort of kickstarting that learning more informally from other countries as well. One more sort of a question before we move over to questions in the chat. Another bit of encouragement to attendees to start popping your questions in the chat for attendees, whether that is for speakers, sorry, whether that is for all speakers or you have one that is specific to a particular country or speaker. So what does the European health data space mean for public trust in health data collection and use globally? Anyone who would like to come to that one first? So Catherine, I know you spoke to that quite a bit in your presentation, and Ilan, you touched on it surrounding your presentation as well. Did you have any further thoughts on how public trust could be impacted globally? Susanna, yeah.
Yes, so in Norway, we are very concerned about the trust, and we are building the systems where citizens can access information how their data are accessed, and this is going to be developed further in relation to EHDS. So the trust in use of data is on top of the agenda, and one thing is also harmonization with the laws, and also the ensuring the IT infrastructure for securing the security of the data and data use.
Brilliant, thank you, Susanna. And I know that citizen information is one of the parts of current TEDx consultation too, so we'll be sharing some more information on that towards the end of the webinar. Anyone else who would like to speak to public trust? Ilan.
I'll see if I can wrap the two questions together for the Australian context for you, Lucy. I think on the first question, for us, the benefit is really around the data gap. We are a country of 26 million people. We have lots of ingredients for success around data interoperability standards. The FHIR standard was actually developed here in Australia and is now a worldwide phenomenon. We are actively learning from the European and US communities around secondary health data standards like OMOP and adopting them. And we don't need to participate in an EHDS to conduct international research if we have adopted that standard successfully. I think one of the themes coming to Trust is really around how the learnings would be around how we can better communicate benefit sharing to participants, to really be transparent about the safe use of data. I mentioned in my presentation, Australia has a consumer controlled repository that features control for both primary use in terms of how data is shared between providers, but also secondary use should it become available. And that really gives agency to the patient around, what they want to do with their data.
Brilliant, thank you. And really interesting to hear sort of that patient controllership side of things too. Catherine.
And actually, I'd just like to build on that answer as well. I think giving those examples of why sharing data is good and the benefits of that, but also I think there's going to be the need to make people more aware of the European health data space and what they're doing, why they're doing it, and prove themselves. And the space needs to prove itself to be trustworthy. So, and also, as I mentioned in the presentation, to have that reciprocal trust between the public and the organisation. So it's going to be some public awareness raising, public understanding of what it's all about, and proving that there's a good reason for doing this and what the benefits are to the public and to society.
Great. Thank you, Catherine. Susanna, did you want to come back in?
Yes, I would like to just add that something that hasn't been actually mentioned is the pandemics, the future pandemics. The preparedness is incremental in implementation of the EHDS, and this can be ensured by better prevention, better public health, better also care, and also the trust is very important, that citizens trust in the advices that are given by the experts, and that maybe we should follow in the future as we learned from our mistakes.
Brilliant. Thank you, Susanna. Very important point to come back to around pandemic preparedness. Just staying with you, Susanna, we have one question in the chat specifically in relation to Norway. How can researchers access and use data now? Is this in a secure processing environment similar to what the European health data space requires?
Yes, we have several secure processing environments, and we have done a gap analysis with all these actors that are providing SPEs. I don't know the details, but as I got feedback from my colleagues who are closely working with it, it's very close match with the EHDS requirements, but it's not perfect, and we are going to work on it further on.
Brilliant. Thank you very much, Susanna. One for everyone, all the speakers. Is there anything that you don't think that Europe, Australia, or Canada are doing well with their health data ecosystems that the UK could learn from or implement in its own health data research service? So what potentially has not gone right the first time round, which the UK can learn from?
When the electronic medical record and the electronic health record was implemented, first of all, in provinces, it wasn't all on the same system. It was all different providers, different vendors. So you have that in one province, and then you multiply that across 10 provinces across the country. It means not only do our laws not allow us to be interoperable in data, we don't use the same electronic health records and electronic medical records. So we are also moving to the within HDRN for some of our analysis to the OMOP model to ensure that we really are comparing apples to apples between Alberta and, say, Newfoundland and Labrador. And the other area, and it's really, I feel a bit bad saying this, we need to make sure that the public are more aware of the health data systems, that when they go to their family doctor, GP, that they understand that their data is going into a record and that these records are used both for health system planning and administrative planning. I'm sure they're aware it's used for their own healthcare planning, but do they understand that it's used on a wider basis in a de-identified way? And I think that we need to develop that to really grow that, to really earn that trust. People need to understand what's happening to their data.
Yeah, of course. Thank you, Catherine. So having those, the two sort of streams of how health data is used clearly communicated to patients. Susanna.
I would like to point to something that is related to my personal experience with working with the health data ecosystems is to understand each other, to try to find a common language. The IT people speak different language than the politicians, and this is incremental in implementing this in the ecosystems.
Thank you. So sort of leaning towards a more jargon-free environment. Ilan.
Yeah, I can comment here in relation to secondary use for research purposes. One of the issues that we have, we have interoperability, we have standards, and we have really good integrated data infrastructure here in Australia. Lots of linkage happening through Population Health Research Network. And but one of the issues is around the timeliness of data release. A lot of our data that's accessed for research is often 4 or 5 years behind in a time lag. And that is when you couple data release practices across multiple jurisdictions, it all just slows down. And that is one of the things that we're looking to OMOP for in that lower risk profile, where you can streamline some of those federated summary statistics studies.
Well, thank you, Ilan. Yeah, that's really interesting that there's sort of such a lag, and especially in line with how quick technology is moving as well, thinking about how you can tackle that. Okay, we have one question to close. Enrique, is for yourself. Do we know which countries have or are going to implement the opt-outs that you mentioned in your slides?
Well, I don't know, but I presume this has been mapped or is being mapped under the current preparation of what they call implementing act. So the different parts of the regulation, there are what we call implementing acts. These are smaller, well, more detailed, but smaller in terms of the legal power documents that detail how each of the provisions is to be operationalized. So definitely we will need to know, so countries will need to report and what we call declare these conditions. So I personally don't know. The issue is on that is that's still a bit of a discussion, is whether this sort of concept of opt-out, absolute is relative, is partial or total. So I mean, when you opt out forever and ever. You opt out for a few years. You opt out, then you forgot to opt in, and can we ask you again? And so these operational issues have to be detailed so that then the behavior of the system regarding this happens. Well, I think in conclusion that we will still take a few years to really know how each country will implement this, because this was somehow new. So this was something that was, let's call it this way, demanded by the European Parliament as part of their, understanding and approval package. So the original proposal based its concept on public good. So data as a public good, and therefore, as long as it is anonymized, it's no longer under the legal footing of the General Data Protection Regulation, and therefore a new right arises, which is the right of everyone to benefit from the data of everyone. And based on that right, we created the fiction of the secondary use of anonymity. And the country, the parliamentarians, it wasn't the member states, and this is the issue. This is what I'm trying to explain. Sorry to take a little bit longer. It wasn't the governments, it wasn't the council where the prime ministers sit that said this was necessary. It was the European Parliament, when voting, that said, even though it is anonymized, there should still be the possibility for people to opt out. And so you see, here's something coming from a legislative body mandating something that you were not even planning to eventually create at the national level. So that's why I'm saying then the different ways the different countries are. I say we're still waiting and seeing. The implementing acts need to come out mathematically by March next year, and of course they are in discussion. So the drafts will be public, I think, beyond September, October, and at the draft level, it is going to be possible to understand what is the text looking like, and then from there, what would be the technical way each country will adopt, and then we could survey the countries and ask them what are they planning to do, and then give the answer to the question, whoever made it. So stay tuned, and we will tell you more about it.
Brilliant, thank you. So in short, Caleb, keep an eye out between March and September next year, by the sounds of it, to see the different implementation plans come from the countries, the member countries for the EHDS. Okay, I'm going to bring a close to our Q&A now. Thank you so much to all of our speakers, Catherine, Susanna, Enrique, Ilan, and Daniel, who was unable to join us for the Q&A, but shared some really interesting thoughts. And I will, move us through to the last little bit of today's webinar. Nadia, if you wouldn't mind pulling the slides back up. Brilliant, thank you. So a little bit more evaluation for us before we let you go. It would be great to get an idea of how much you feel you know about the European health data space right now. So following hearing from all of our brilliant speakers about how they are aligning to the European health data space and their respective challenges in their own data networks. If you could once more scan the QR code or join at slido.com and pop that number in. And share how much you feel you know about the European health data space right now. Okay, let's move it over to the next poll, please, Nadia. So last question for today. What importance or relevance do you think the European health data space holds for the UK? So we've got very important and important kicking us off. Okay, nice. So we had a few of you sitting at, moderate amount, and a few sitting at important. So we do still have a little bit of work to do on your understanding, which is great for us because we haven't actually finished our engagement around the European health data space just yet. We're going to be sharing explainers, summary reports, and case studies in coming weeks. So do keep an eye out for those. And that is everything from us at UPD today. So we will wrap up there. Another huge thank you to our speakers today, Enrique, Ilan, Danielle, Susanna, and Catherine. To Wellcome Trust, who very generously have funded our EHDS work. And of course, to the attendees who joined us on the call this morning. I'll give you back 3 minutes of your day. Enjoy it, enjoy the sun, hopefully, and we'll see you again soon. Thank you very much.